Hi, Larry.
All right, is my screen sharing up? You can see my screen?
Oh, Larry, can you hear me?
Yeah, I can hear you. Can you see my screen?
Okay, wait, I think our tech team just needs to get some things set up.
Are you introducing me?
Oh, yes, I am. I'll introduce you. We have a few minutes, I think, before we get started.
Oh, wow. I don't know, on 8 o'clock, they started on the button, but that's fine with me. Have you heard this talk?
I don't think that I have. No.
As the
You need to-
introducer, do you have to sit through it?
Are you set? Okay, yeah, no, I didn't. Okay, we're okay to start. Oh, okay. Okay, so, let me just check the time. I guess we're, yeah, okay.
Yeah, I don't mind waiting a couple of minutes. People have to change rooms, whatever. So if you want to wait 2 minutes, let people settle, it's fine. Because we've got.
Yeah, why don't we just wait like a couple minutes? I don't think.
Okay, and is anyone in there, anyone in the room with you? I have on Zoom, I have like 2 or 3 people. Anybody in the room with you?
Yeah, we have some audience members here as well.
And we have an hour, is my understanding, right? This runs through lunchtime.
Yeah, yeah.
So we have 1 hour.
Okay, so why don't we get started then? Okay, so welcome to those of you in the room and online. It's my pleasure this morning to introduce Dr. Larry Amsel. Dr. Amsel is an associate professor of clinical psychiatry at Columbia University and New York State Psychiatric Institute in New York, New York. Dr. Amsel is associate director of the Global Psychiatric Epidemiology Group, where he applies decision science tasks in psychiatric research and explores the role of biological mechanisms and decision science to a range of outcomes, including suicidal behavior. Dr. Amsel, known as an outstanding teacher, also trains clinicians, especially pediatricians, throughout the USA in psychological assessment and treatment, having trained thousands of community clinicians in evidence-based treatments for PTSD and complicated grief. He is a co-investigator on the Guyana Wellbeing Study and co-investigator on the Columbia University of Guyana Research in Injury and Trauma Training program. Okay, and with that, welcome Dr. Amsel, and we'll turn it over to hear your talk.
Okay. So what we're going to be talking about today is a mathematical model of complicated grief. So it's sometimes I say complicated grief, but that's not the right name of the disorder. There's a disorder now. It's been a disorder under the ICD system, under the international system. It's been a disorder for a long time. It just became a disorder over the summer as far as the DSM-5 is concerned. And it's called prolonged grief disorder. So prolonged grief disorder. And we'll talk about what that is. But what I want to do is I want to give a talk about understanding it, a mathematical model of it, where other ways of saying this is computational psychiatry. For those of you who are familiar with the term computational psychiatry, which is a fast emerging paradigm within psychiatry, and I think it is one of we've had the psychiatry was dominated by Freudian mind concepts, and then it went through a period of biological psychiatry, and that biological psychiatry has had its great successes, but also some limitations. Different alternatives have been suggested, including the RDocs. Computational psychiatry is one approach to another approach to understanding psychiatry and understanding mental health. So let's start with not a mathematical, but a poetic model of grief. And this is Emily Dickinson, her model of grief. A bustle in a house the morning after death is solemnness of industries enacted upon the earth. The sweeping up the heart and putting love away, we shall not want to use again until eternity. And like with every other emotion in the universe, I think Emily Dickinson is one of our best articulators of the sense of emotions. And I think in this, she captures the essence of grief. So what's a mathematical model of prolonged grief? Well, the thesis of mathematical modeling is that psychiatry is, to a large extent, the study and treatment of pathologies of motivated human behavior. It's not 100% right. It's not a 100% best definition, but I think it's a very good working definition of psychiatry, for which it certainly helps differentiate psychiatry from neurology, in which both of them we deal with brain disorders. But in psychiatry, for the most part, we deal with motivated human behaviors, even when the person doesn't necessarily have complete control of that motivation. So in obsessive compulsive disorder, those are motivated behaviors, even if the person doesn't have complete control over that motivation. So all motivation involves decisions, choosing between alternatives, because there are expected utilities, expected goodies, expected something positive that comes out of making choices. So the belief is that large parts of psychiatry are defined by clinically applying decision theory, rational choice theory, utility theory, reward learning theory, and the multi-agent extension of these, which is game theory. Now, for many of you might not be familiar with this, I will try and explain these terms as we go on, but understand that decision theory and decision science has been around for a long time. So has a game theory. Rational choice theory has also been around for a long time within the social sciences. And there are people who believe that rational choice theory is actually a unifying concept that brings many of the social sciences together. What are you talking about, Dr. Amsel? Everybody knows people aren't rational. What are you talking about, Dr. Amsel? Everybody knows that behavioral economics has turned over rational choice theory. So we'll discuss that, but it's actually only partially true. I would say that my understanding of behavioral economics, which is the uniting of economic theories and psychological theories, they challenge simple rational choice theory. They challenge the simple notion of a rational economic agent as defining a human being, and they introduce psychological factors into that. But the framework is still one in which I use considerable amount of machinery from rational choice theory in order to understand human behavior. So that is in general mathematical modeling, the notion of mathematical modeling. And I, for one, this has been applied to multiple things. Quentin Hughes in Switzerland has a very fascinating model of depression. I have models of OCD, grief, anorexia nervosa, and other things based on these kinds of things. Again, using decision theory, rational choice theory, utility theory, and reward learning theory. I'm going back because, again, I don't know, I'm not with my audience, so I don't know how much my audience is aware of these things, and I want to help bridge us into the set of concepts. So I will say one thing that you might recognize, even if this sounds out of your realm, is that when we talk about post-traumatic stress disorder, we're talking about fear learning and reward learning. Reward could be positive and negative reward. So when it comes to PTSD, people already are totally on board. People understand that post-traumatic stress disorder is an example of what we call one-shot learning. one-shot reward learning, but it's not reward, it's fear, but it's, again, the same notion that you learn to fear things. So that's one example in which psychiatry has long accepted that reward learning is central to the pathophysiology and its description in PTSD. So utility theory can inform how we model prolonged grief by delineating the roles of reward learning, fear learning, and decision-making in the grieving process. Game theory can also be used to model the cognitive and emotional paradoxes observed in the grieving process, especially by looking at grief's failure mode. Okay, so we'll first focus on prolonged grief. So pathological grief is now called prolonged grief, occurs in about 10 to 20% of people after death of a partner or someone's very close to them. It has interesting overlaps with major depression because there seems to be anhedonia. People have no pleasure during the period of time that they're in prolonged grief. There's sadness, there's withdrawal from society. It overlaps with PTSD because there's shock and disbelief, seeming contradictory beliefs as there are with PTSD. There's anxiety. It has the possibility for generalization. Generalization is the phenomena in anxiety, where when I'm fearful of one thing, that one thing gets exaggerated and I become fearful of all kinds of things. Like maybe I'm first fearful of bridges, but then that then generalizes and I become fearful of all transportation modes. In both of PTSD and in prolonged grief disorder, there are intrusive memories. And both of them respond to an exposure form of cognitive behavioral therapy. So while it is not completely well understood, thanks to, for example, Kathy Shear, who is at Columbia, she's at the School of Social Work at Columbia, and she has devoted the last 20 years of her life to exclusively studying prolonged grief. And there's a lot of advancements in this theory. So risk factors are now better to understand. There's a validated diagnostic measures, which we never had. And there are controlled trials which show that a particular kind of therapy, namely a modification of the therapy that was used for PTSD, which is Edna Foa's cognitive behavioral therapy called prolonged exposure. Turns out that a modification of that is very effective. So prolonged grief, 6 phenomena in search of a plot. So in Mourning and Melancholia, which is a monograph by Freud, he details Freud. Whatever you think of his theories, Freud was a very close observer, a very, very close observer of human behavior, and it is still worthwhile to read some of his observations. So he was observing grief, and he said grief involves intrusive memories of individual experiences that were had with the deceased. So it's intrusive memories. And if you stop to think about it, we sort of take this so for granted that we don't even observe it. But he was careful in observing and documenting this. Intrusive memories. People sit and they have these intrusive memories of the individual experience with the deceased. This again is part of human life. It seems so natural. It seems also almost not worth talking about it. But then if you take a step back and you're like, why, that doesn't seem helpful. Why would I want to have these intrusive memories of the person I just lost? I'm trying to get over this. Okay. He also noticed that there are changing emotional responses to these memories. And he called this process of the changing thing decathexis. Now, decathexis is an 18th century word. It means taking the energy out of something. Of course, they didn't have the biological prerequisites to understand this in the terminology we might use today. But I think he was right in his observations. So the question that it raises, have social animals, including elephants, by the way, who seem to have a very complicated mourning procedures. They have specific burial sites, etc. So have social animals evolved grief algorithms, which involve these features that Freud noticed and that we all go through? And how would we update his observation in today's scientific language, especially how would we update that in the language of reward learning and decision making? 2 is the obsessional nature of even normal grief. So I'm going to talk about two things. I'm going to talk about normal grief and then what goes wrong. How does normal grief work? What goes wrong with normal grief? And that will give me prolonged grief, right? Just like, what are moods? How do they work? And when it goes wrong, then I get depression. So first I have to understand how it is when it goes right. So normal grief, again, involves repetitive ruminations over painful and unwanted memories. How could this be helpful? The paradox of prolonged grief. Sometimes patients will tell you that they would rather continue in unremitting grief than give up the attachment to the deceased, right? And this seems like a quasi-delusional attachment to a lost object. Okay, these patients have complete insight to this. They're not delusional, and it's a paradox, right? They would rather be in pain, but in some way that's not delusional. It's kind of a fantasy. In some fantasy fashion, they remain attached because that attachment is so important that they remain attached. They say, I don't want to complete a grief process. I don't want to give up my attachment to this person. And we have to help them to figure out how to do this. So this, I think I sometimes get ahead of myself because I mention things just in my talking that are on slides, and here's an example of that, because I already mentioned that prolonged grief looks in many ways like major depressive disorder, and in other ways it looks like PTSD. But interestingly, people who have prolonged grief, if they look sad and you say, "Oh my God, they look like they're depressed," doesn't respond to the major medications that are helpful for major depression. Prolonged grief does not respond to that. Now, I don't want to confuse people because there's a whole controversy about this. It's possible to have prolonged grief and simultaneously have a major depressive disorder. Some people get kicked into a separate major depressive disorder, and that's a different animal, and that will have some responses. But prolonged grief, straightforward prolonged grief itself doesn't respond to antidepressants the way depression does. So it doesn't look like depression, but it looks a little bit like trauma because it seems like it's a trauma. So what is the nature of this animal? And it does respond to exposure-based CBT, just like PTSD. So it seems to be like, is it a horse or is it a cow? Which is it? It seems to have features of each. Prolonged grief also has anomalies of memory. It turns out that people who have reduced autobiographical specificity in their memories have high levels of prolonged grief. So if you weren't good at doing autobiographical memory, of remembering incidents in your life, as a cognitive feature, and nothing to do with the deceased, nothing to do with grief, but a cognitive feature of you is that you're not great with individual memories associated with your past, then you're at greater risk for prolonged grief. Why? Why should that be? Why are those connected? So I already mentioned, again, Quentin Hughes and others have postulated that decision theory models of depression. And what he postulates is that the way depression works is that we usually, and here I will have to go into some background because those of you who are not familiar with decision theory and with the notion of expected utility, let me just give a brief background so we can all be on the same page. So the idea of expected utility is the notion that, for any action, I know that there's like a series of outcomes, and I have an expected utility of value, right? The goodies of it. So, if I go to a gelato stand, my expected utility for the gelato is very high. I know that I'm going to, again, expected utility means what do I think I'm going to enjoy in future enjoyment? What do I think I'm going to enjoy? And these expected utilities are what the value I think I'm going to get out of a certain experience. And the way that that people who do, for example, animal work on this or rat work on this, think about it, is that, a rat has a map of the world in which all different kinds of things are attached to it. I have the utilities for all different kinds of outcomes. As you sit here right now, you yourself have a map for all the different kinds of things that could happen during lunch. Sandwich that can happen with lunch, what you like, the sandwich, a pizza that you might like for lunch, just having coffee. So for all the possible outcomes, you have expected utilities, which means expected valuations of all those possible outcomes. So what Quentin Hughes postulated was that what depression was, in its essence, was that my expected utilities for everything just fell off the ground, that my expected values for everything, I just did not think that anything's going to have value. So that a depressed person thinking about lunch would say, I don't care about pizza. I don't, that they once loved pizza, now they don't care about pizza. And that's true for all of the activities in life. They just don't have any positive expected thing. They don't think that it's going to give them any enjoyment. It may actually give them enjoyment if they do it, but they don't try because they don't think it's going to give them any enjoyment. So that's his model, and we're going to borrow from that model as well. So let's think about how, again, in the normal situation, how do I learn that I like something? So there's this notion of CU is CU of X means the consumptive utility of X. That just means how much I actually enjoy pizza. When I actually eat pizza, how much I enjoy it. And the expected utility of X means how much I expect it, my anticipation of eating the pizza, right? If X is the pizza, it's my expected utility, right? So any experiential occasion, OJ, something like that, going to a restaurant, right, has a bunch of different attributes to it, right? And the consumptive utility of it is the consumptive utility of all of the attributes in the restaurant. So when I go to a particular restaurant, as you know from restaurant reviews, there are all these different things that I enjoy in the restaurant. I enjoy the food, but I enjoy the service. I like the music that they're playing. So my consumptive utility is a consumptive utility when I'm actually experiencing it of the cuisine, of the location, the music, the side. So once I do go to a restaurant and I do that, and I learn what I learn, and this is reward learning. I learn, I like the cuisine. I really like what their cuisine is. I like the location. So I end up having in my brain, I learn what my expected utility is for that thing, for that event, that particular restaurant. Well, what about people? Okay, so in relationship formulation, the occasion J that is shared with Bob. So I went to the restaurant, and if it is an occasion which was shared with Bob, then look what happens. I have a consumptive utility, which means how much enjoyment I get out of being in the restaurant. Okay, I hope people understand the math here is quite simple. It's just, there's no math here. It's just symbols. And you can say this in English as well, which means my consumptive utility for being in a restaurant with Bob, well, Bob seems to add to it because I'm with Bob, and then there's the music, there's the service, there's the atmosphere, all of the things about that restaurant. And if I like Bob and if I enjoy being in the restaurant with him, then my consumptive utility of being with Bob in the restaurant is greater than my consumptive utility of being in the restaurant and getting all the things out of that restaurant, the ambience, all of these kinds of things. I learned that that's better. When I'm with Bob, I like that restaurant better. My total enjoyment of the restaurant is increased. And so my expected utility is better. So I can donate it simply say my expected utility of sharing the restaurant experience with Bob is greater than my expected utility with Bob. I prefer to go to the restaurant with Bob. That's all it means. I learned that I prefer to go to the restaurant with Bob. So utility loves company. Now, if it turns out that this is true over many experiences, right? Then I generalize and I come to the conclusion that I like Bob. I not only like being in the restaurant with Bob, but I like Bob. And the one way to say that is that if A is a variable over all possible experiences, then I come to have the expectation that my expected utility of doing any activity or many activities, doing them with Bob is greater than my expected utility of just doing that. If I go to the beach, my expected utility of going to the beach with Bob is better than my expected utility of simply going to the beach. So my expected utility of all of these events, so the expected utility of adding Bob into any situation increases my value of that thing. So is this what we mean by attachment? Is it that from the sum total of these individual experiences, there's a name for this, it's called dating, right? It's called dating. And ideally, you go on different kinds of dates. You go to the movies, you go to the beach, right? And in each of these situations, I think that, Bob enhances my utility for the experience. And so maybe this is part of the definition of what it means to attach to Bob. So we slipped in an assumption here. We think it's reasonable that we come to like people through their enhancing the utilities of shared experience. We like people because they enhance our experiences. Now, this is different than attachment theory, which just says I'm attached to the person and that's it. I'm just attached to the human being. And I don't think of it in terms of individual experiences. But I want to argue that the way we learn to like people is through individual experiences, and that this continues to be part of this notion of attachment. So we do not attribute utility to persons directly. I'm saying I'm going a little bit differently than Bowlby attachment theory. I'm not saying I have a certain utility for somebody, but I have a greater utility for my experiences with that person. I hope that's clear. Now, by the way, it's important to distinguish between different people. My experiences, my expected utility, the expected here, sub Sally means Sally's expected utility. So this is Sally's predicted, maybe different than Bob's, right? So just I want to make sure that I introduce the fact that different people may have different experiences. Well, this isn't the whole story, right? Because when I go to the restaurant with Bob, right? It's not only true that when I first go to the restaurant with Bob, oh my God, I like being at that restaurant better with Bob than I did going to the restaurant by myself. But after a while, I also come to realize that Bob likes being at that restaurant with me. So if I'm Sally, my expected utility of being, remember OJ is the restaurant, my expected utility of being at the restaurant with Bob, is enhanced. But then there's also an additional utility that I get, and that is I get enjoyment out of the fact that Bob gets enjoyment out of being with me. So I hope those of you who have some familiarity with this starting to see where this is going towards a game theory kind of notion. So what I'm saying is that whereas if I'm just in the restaurant, the total of my enjoyment is simply my expected utility for the restaurant experiences. But when I'm with Bob, I enjoy the restaurant with Bob better, and I enjoy the fact that Bob enjoys me. So that's called R, which is a reflected utility. I get pleasure out of the fact that Bob gets pleasure being in the restaurant with me. So there's a whole complicated set of expected utilities. And when I think of that restaurant, I think of going there with Bob, and I think of my experience is enhanced because I'm there with Bob, and my experience is further enhanced because Bob loves to be at that restaurant with me, and I like that. So this is a technical point, whereas reflected utility, for those of you who understand that, the reflected utility is recursive. So we can skip this part. It simply means that not only do I enjoy the fact that Bob enjoys it, but Bob enjoys the fact that I enjoy the fact. So it's reflected utility. But since on each reflection, each reflection will be reduced, the total utility does converge. Technical point for those of you. So now let me stop thinking about the restaurant. Let me think about, I went to Bob with this restaurant, and we went to the beach. We went to the beach together. We went to Guyana together to a conference. We did all of these great things together. So I start to abstract away, and I come to realize that everything that I do with Bob is better. And then if I'm Sally, then the notion of my attachment to Bob, this is the summation sign. It's don't worry about the math. It simply means that in my attachment to Bob, I think of Bob as the enhanced utilities of everything in the world, right? The beach is better, going to dinner is better, everything is better, this is where relationships are, right? Everything in the world is better if Bob is around. So my attachment to Bob, I then come to sort of define my attachment to Bob. Pay close attention here to the additional utility I get out of my experiences in life. My attachment to Bob, I'm defining it in an economic terms, that my attachment to Bob is defined by the fact that everything in my world is better because Bob is there. So my expected utility for all activities in my life, or many activities. Maybe I don't like to go to the opera with Bob because he's a pain in the ass and he snores. So I don't like to go to the opera, but everything else I like better with Bob. And when I'm saying it's not that, we all know this, that's true, yes. But I'm saying maybe that is part of the whole attachment. This expectation that the world is different with Bob. So that's the holistic relationship. And again, I'm not completely displacing Bowlby here, but I am encroaching on his territory. I've said this already. And by the way, my evidence for this is when you go on a trip without Bob, what do? You send back a postcard that says, "I wish you were here." Why do you do that? I wish you were here. Why do I wish you were here? Well, because the experience, here I am in Florence, I'm at the Uffizi Gallery, and I'm looking at my favorite painting, and I say, I wish Bob was here with me, right? Why? Because he would enhance my experience with that. Okay. So notice this is the opposite of Quentin's model, where in depression, everything is decreased, right? This is saying what human beings are antidepressants. They increase my utility for everything. Well, absence make the heart go fonder, right? There is an anticipated gap in utility. So fine, this is how relationships form, but what happens if Bob dies? Well, then Bob is away, and I think of it, oh my God, I miss Bob, Bob's dead, Bob's gone. Again, a Bowlby kind of attachment thing focuses on that individual being gone, and I'm attached to the individual. But what I want to point out to you is, and if you've ever lost somebody, you recognize that even when you're not thinking about the person, when you walk around, I remember when I lost my mother of blessed memory, that I would walk around. I remember walking up Fifth Avenue. I was looking in some of these shops that I used to love looking into the window, and it was like, who gives a damn? This window. Who cares what's in that? What's in that window? Walk past a Starbucks. I used to love the coffee there. I said, who cares about the coffee? So you actually have these experiences. That it's not just you're thinking about the person, but your experiences in the world are diminished. So what I'm saying to you is that when somebody dies, who you've had this experience with, then your expected utility for all of these objects, just think about the restaurant. My expected utility for that restaurant drops. So I think going to that restaurant, my God, it's a dreadful thing. Bob's not going to be there. My expected the utility that I used to have for this restaurant has suddenly dropped. And I know that. And that restaurant's not going to feel good, right? So here's the expected utility as I defined it. Don't worry about the math too much, but here was the expected utility. Here's what I know I'm going to get right now. All I'm going to get, if I'm Sally, all I'm going to get is the utility of the restaurant without Bob, as it was before I even met Bob. That's all I'm going to get. And this is what I had been expecting. And so what I have is this gap. There's a real expected utility gap. My expected enjoyment of that restaurant has fallen through the floor. And this is true for all of these different things. So here's what I call the grief equation. And the grief equation is simply that summed over all experiences and over all possible experiences in the future. So I'm summing over restaurants, and I'm summing over all the different times I could possibly visit that restaurant in the future. And for each of those, I experience a loss. And I call this the real death tax, because for each of those, in my mind's eye, the map of my world, which is a utility map of I can enjoy this, I'm going to enjoy that, I'm going to enjoy the other thing. The utility map in my mind suddenly drops down, where all these things are have lost their utility, they lost their value, they have much less value. And by virtue of having much less value, they might even feel like negative value because the loss is what's going to be experienced. The loss is what's going to be experienced. So how do I deal with all of this? Well, it turns out that Freud figured it out. He didn't know game theory, but he kind of figured it out because he said he noticed that what people are doing is discretizing, making discrete grief to counter generalization. In other words, he's saying, I can't grieve a whole person in the Bowlby model or in Amsel's model. I can't grieve the change in every event that's occurring, every restaurant, every possible thing. What I do is I discretize it. In other words, I think about a single experience. Maybe I think about the first time that I went to the restaurant with Bob, and that comes up in my mind, that first restaurant experience. And what am I doing when it comes up in my mind? Well, Freud said some vague thing about decathecting, detaching experience from it. But what I say is, this is exactly what I do in PTSD treatment. It is an exposure experience. I'm exposing myself. I'm remembering the restaurant with Bob, and now acknowledging that Bob's not there and what the restaurant's going to be. So I am exposing myself to the restaurant experience loss, the loss of that restaurant experience. But I'm doing it historically, so it's a single experience. It's like it's impossible. It's impossible for me to grieve, to make my changes across the entire Bob, losing the whole person, losing all of this. So I do it one memory at a time. And with one memory at a time, I expose myself to that memory and I go, yeah, okay, expose myself to that memory. I accept that Bob's not going to be there. I expect that one experience, I can expose myself to that. And the fear learning that I'm going to experience a loss is therefore controlled. So in other words, we can now partition loss by discrete contexts or occasions. Loosely speaking, it reverses the reward learning process, which again, remember when I did the reward learning process in terms of getting to love Bob, I did it one thing at a time. I call this the zipper theory. We only deal with individual occasions, avoiding the overwhelming experience of summing over all of them. Within each occasion, repeated exposures, I incrementally transform the expected gap because I now, in my mind, update that gap. So that when I go to the restaurant, it's not a shock because I've exposed myself to the fact Bob ain't there and I'm not going to get that big utility that I did before. I'm exposing myself to each of these. So those I go into some a little bit more mathematical detail about this discretizing and incrementalizing it as I do it one piece at a time, one memory at a time. So the summary is I can now partition the loss into individual occasions, and each occasion by repeated exposure in my brain, which is what I'm doing when I'm grieving and sitting at home and doing my grief work. This is what grief work is. With each such experience is painful. It incurs a cost. Well, why would I do this? Before I said, well, why would a person do this? Why would I have this thing that Freud described where I just lost somebody? Why am I torturing myself with these memories? But I have to torture myself with those memories or I couldn't go on in life. I have got to do an internal cognitive behavioral exposure therapy to these experiences so that when I go to the restaurant next time, it is not a trauma for me. I don't experience that gap in utility because I prepared myself. So that's the zipper theory of attachment and loss. And that explains normal grief. That explains normal grief. So according in this theory, that is what normal grief is. Wow, that's a whole lot of work just to get it to what normal grief is. Yeah, but when you do a whole lot of work to get to what is actually the correct theory, you then can maybe understand what can go wrong. And what I'm suggesting is that when we understand normal grief this way, suddenly prolonged grief makes much more sense. I get to understand it because what does prolonged grief have to be in this theory? Prolonged grief, when I have a pathology, when I have pathology, pathology is always, I understand the physiology of a process and I understand its failure modes. Right? So I'm telling you, this is the physiology of grief and what are its failure modes? Well, the failure modes, let's take a look at what the failure modes are. What would be the failure modes in this case? Well, if that's the normal thing, what if I'm unable to do it? What if I'm unable to discretize on occasions? What does that mean? Well, you'll talk to people and you'll say, you went into grieving them and said, well, I started thinking about the first time we went to a restaurant, and then I just started weeping because I realized that Bob is gone. And so people, one of the things that would be that we would predict would be a cause of prolonged grief is that people having inability to focus down on individual occasions. And there are people who have trouble doing that. They have trouble holding individual occasions in their mind because they just move to generalizing and thinking about the whole entire loss, and they cannot deal with one memory loss at a time. So the inability to tolerate doing an individual thing, also the inability to tolerate habituation, which is something we see in post-traumatic stress disorder as well, that you can't do the exposure. You simply, the idea of going back to that memory is intolerable, and people cut down. They cut down the process that their brain is trying to do of taking you back to that memory and walking slowly through that memory and experiencing the anxiety and the loss that takes place. So there are people who maybe cannot do that. They can't do the grief work as described in this particular fashion. So that could be the case. What other evidence do I have? Well, if this is right, then the grief treatment, the prolonged grief treatment should address these problems. So if this theory is right, then there should be something in the evidence-based treatment, because people who created the treatment for grief, they didn't have this theory. They just went out there and tried things and something worked. But the signal from what works should help me understand whether or not this is true. And the answer is that the prolonged grief treatment does speak to these things because it reinforces commitment to repeated exposure. What I do in those things is I talk to people about individual experiences that they had with Bob. I reduce the totality of the loss because I do imaginal conversations. So one of the things I do is an imaginal conversation with the deceased, okay? And I reset the grief process to the initial node. Also, because the therapist is sitting with a person as they're going through the grief, I raise my tolerance for the cost of exposure, for the discomfort of these individual exposures. And so I allow for this new reward learning process, which I am now saying that a reward updating. So grieving, for those of you who are familiar with the terminology, grieving is, it's not a Bayesian updating because that would be probability, but it's a reward learning updating of all potential experiences in the world. Grieving process readjusts my expectations. And as soon as I say that in lay language, it's like, of course, what do you mean? But actually that supports this theory, right? Because if I said to you, do you think that grieving work helps you adjust your expectations to what life will be like without Bob? You say, of course, that's what grieving does. Well, if you believe that, then you are halfway to believing this theory. So again, the grief treatment turns out it supports imaginal exposures. It also supports in vivo exposure. We encourage people to get in touch with objects that remind them of the deceased. For example, dealing with their clothing. It reduces the guilt around the expected utilities, especially the altruistic utility. People sort of say, how can I go back to the restaurant without Bob? I feel so guilty. He's not here to enjoy it. That's the altruistic utility that we talked about, reflected altruistic utility. So the grief process helps you think that through. So what are some future directions? We're also always looking for collaborators. If anybody in the audience is interested in this stuff, you could get in touch with me. We could talk about doing some further work in this and try to plan some empirical work. So using mathematical psychiatry, using models from decision theory and game theory can improve my understanding of the complex phenomena, such as normal grief and prolonged grief. Using these insights from game theory perspective, we can better see several ways. And I didn't talk about the game theory model. By the way, there's a game theory model of this as well. I talked to you about the utility theory part of it, which is the single decision maker, but there's also a game theory model in which the two game players are the person and their imagination of the deceased. And there is a game that goes on, which is too much to present in a single lecture, but I'm happy to share that with anybody who wants to know how that other part works. So it opens up new areas for empirical study. I want to acknowledge research assistants who've worked with me. I have no conflicts of interest. And since I started with a poem by Emily Dickinson, I'm going to end with a poem by Emily Dickinson in praise of the human mind. The brain is wider than the sky, for put them side by side, the one the other will contain with ease, and you beside. The brain is deeper than the sea, for hold them blue to blue. The one will the other absorb as sponges buckets do. The brain is just the weight of God, for heft them pound for pound, and they will differ, if they do, as syllable from sound. Thank you for your attention, and I'll take questions.
Do you have questions from the audience?
So thank you for this really great talk and presenting this game theory model. It's very interesting. So I just wonder how you choose the occasions that you're modeling.
Someone, please repeat the questions. It's a little hard for me to.
The question was, how do you choose the occasions that you're modeling?
Wonderful question. And what is the order and the sequence in which you do that, right? You go backwards from now in time to the beginning, So how does your brain choose? How does your brain choose them? It seems to me that there's two possibilities, and it's an empirical work that needs to be done. I don't know the answer. One possibility is you choose the most important, which might be the first time, if you're dating someone, this is your husband you're talking about, it might be the first time that you went somewhere together. So that might be one way that the brain might be protective, and it might order them in terms of what you have to do. So maybe if this is your favorite restaurant and you really want to go back to it, so the brain starts thinking about that restaurant or other kind of experience, or that could simply be also the first time that you had the car together, or you bought this house together. So your brain, so it may order them by importance, it may order them by time, or it may order them by anticipation of what I need to do next in my life. I'm not sure. But I appreciate the question, because it indicates to me that you you got the point, of the argument.
Thank you.
People can ask more simple questions, because I'm familiar with the fact that I'm introducing a lot of concepts here. I usually give this talk to people who are already experts in computational psychiatry, and so it just becomes an application of already thing. But I know that I'm trying to teach you a lot in this one talk, so I hope you got little pieces of it at least. And but don't be shy to ask questions. No question is too simple here when you've had to absorb all this material.
Let me ask a question, which is that you said a little bit, it's about treatment and possible implications for treatment. You said a little bit about how the theory matched up well with what's known about what works for treatment. And I was wondering if there are any ways in which anything the theory says about, or could be used to kind of enhance that, or other, kind of improved treatments.
Yeah, so that's a great question, and the way treatments are developing, and I think the main treatment I'm aware of is by Kathy Shear's treatment, which borrowed again from Edna Foa's treatment for PTSD, and she borrowed elements of that. And the way that they did that was purely empirical. In other words, they sort of had a theory, but not this theory. But mostly they just tried different kinds of therapeutic interventions and saw whether they worked. I think the way that they do talk about resetting the grief process. I think it would be very helpful. What we could do is explicitly explaining to people, asking people where they think their grieving process went wrong, sort of checking in on them on these failure modes. And sort of, in other words, one of the things they don't do in this treatment thing is they say, well, you know, when you sit down and these memories come into your mind, do you find that you're completely flooded? And are you able to sort of take one memory at a time? And if not, maybe I can help you, and you can do it by doing it out loud. So I think actually just doing a psychoeducation of describing these failure modes to the patient, as you do in anxiety disorders, might be an additional helpful step that hasn't been tried. It's a good question. Great question.
I think we have a question in the chat. I'm just trying to figure out how to.
Trying to figure out how to get to the chat. When you have something open, it's sometimes hard to. What sources do you recommend if we're inclined? Well, okay. Learning and computational.
Okay, I think it just disappeared. Wait. Okay.
So the question I see, let me ask the question I see in the chat box, if I may. The question is, how would this be impacted by somebody removing themselves from the environment in which they knew that individual? That is mourning. That's precisely what it is. What you do is you remove yourself. You don't go to the restaurant, because if you go to the restaurant, it's going to be very, very painful. So to the extent, that's why you see that people in mourning tend to remove themselves. Different cultures make this formal or informally different. But, you know, for example, in the Jewish culture, people literally do not go out of their homes. They stay home for a week. They are not allowed to well, of course, their home is somewhere they shared also, but they're not allowed to go to other environments which they shared with the person. So I would say that's exactly what you do, is you remove yourself from those situations, because they'll be too painful to handle until you have changed your expectation of what those things are. So that's exactly part of it, is isolating yourself from those experiences. You don't go to the beach. You don't go to the beach as far as mourning. In this theory, the healthier thing is not to go to the beach. Sit at home, think through those events, and once you've thought through those events and you've prepared yourself, then you can go back. Someone else asked me, I just want to get a title for you. So there's a recent book by Peggy Series. Her last name is S-E-R-I-E-S. Peggy Series has a recent book. Most of the books on computational psychiatry are very complicated, and they're for researchers in this field. But Peggy Series, S-E-R-I-E-S, recently written a book that is more appropriate for beginners in this, people who are just introduced to this field. So that's the second question in the chat.